Well, it is just past 2 o'clock, so I think it's reasonable to get started. There may be some more folks joining as we go along, but I would like to welcome you all to this afternoon's peer webinar. Our group, my name is Norm Buckley, the nominated principal investigator for the Chronic Pain Network, and this series of webinars, which now numbers 4 or 5 at least, maybe more, although this may be the final one, put together by a working group from our Knowledge Translation Committee and our Patient Engagement Group to provide information to a pretty broad audience. We've had great turnout. We appreciate your all being here today on issues to do with patient engagement and research, particularly in pain research. And this is also a good week, in addition to this webinar, with our guests that you'll hear about in a few moments. On Thursday afternoon, the Canadian Pain Society is presenting a webinar also on chronic pain in children and the impact of COVID-19 on pediatric chronic pain. And that's also going to be a very interesting webinar Thursday afternoon. So just check that one out. But I'm going to introduce your co-hosts this afternoon, Leslie Singer and Nader Gassamloo, and I will let the two of you go on. But thanks very much, everybody, for attending today, and welcome to everyone.
Thanks a lot, Norm. I'd like to thank everyone for joining and really thank the SCIP team for taking the time to join us, to share with us their experiences with knowledge translation. Leslie and I, have really been hoping to get the SCIP team to present here, and it's been a long time in the works, and we're really thrilled to have them join us here and give us some insight into the amazing work that they've been able to do over the past few years. I'll go ahead and start introducing the team along with Leslie. So first off, Catherine Deeb is going to be leading the session and is the SCIP Patient Engagement Coordinator. Catherine has lived with chronic pain since the age of 16. She was a pediatric pain patient at the IWK Health Center in Halifax in Nova Scotia, and is now an adult pain patient at the QE2 Health Sciences Center in Halifax. She was a patient on Dr. Katie Bierney's Partnering for Pain project. Katie, most of you might know through the CPN as well, where they established a top 10 list of pediatric pain research priorities. She advocates for patient engagement in research and healthcare, and her passion for patient engagement has led her to Solutions for Kids in Pain, or the SCIP team, where she became the patient engagement coordinator.
Next, we'll have Paula Robeson. Paula is a knowledge broker for Children's Healthcare Canada in Ottawa. In 2019, Paula joined Children's Healthcare Canada as the Senior Advisor, Knowledge Mobilization, and the SCIP team as a knowledge broker for the National Hub, which is located at the Children's Healthcare Canada. Paula has pioneered the knowledge broker role in public health through her work with health evidence at McMaster University. For almost 2 decades, Paula has led national and international knowledge mobilization initiatives at various organizations, including the Canadian Centre of Substance Abuse and Addiction and FRAME, an international network focused on improving access to quality of and outcomes associated with youth mental health and substance use services.
Then we have Chad Larrabee, who is a knowledge broker with the Hospital for Sick Children in Toronto. Chad joined SCIP and the Sick Kids with a wealth of experience in program development, partnership creation, and community outreach. Having developed provincial networks and programs for a variety of vulnerable populations in the past, Chad is passionate about unifying the stakeholder voice and harmonizing evidence-based messaging. Chad completed a master's degree in health sciences with a specialization in neuroscience and has taken the knowledge translation certification course at UOIT.
After that, we'll have Elise Ryder, who is a knowledge broker at Stollery Children's Hospital in Edmonton. She's a knowledge broker for the National Knowledge Mobilization Network, Solutions for Kids in Pain, and is based at the Stollery Children's Hospital in Edmonton.
And last but not, oh, sorry.
And Department of Pediatrics at the University of Alberta. Dr. Ryder has been working as a knowledge mobilization professional for the last decade and is passionate about co-development of knowledge translation initiatives with patients and families to improve their healthcare experience.
And finally, last but not least, is Erin Aubrey from the IWK Health Center in Halifax, where she's a knowledge broker. Erin comes to SKIP with a broad range of experience, having worked in both basic and clinical research within provincial government departments, health authorities, and university settings. Erin is passionate to work in partnership to close the gap from research to evidence-based practices at the bedside as efficiently as possible by fostering innovation within our health system. Using her extensive experience in applied research methods, program evaluation, and stakeholder engagement, in working with the diverse SKIP team, Erin is keen to be leveraging her skills and experience to give children in pain a voice and to further promote Canada as a leader in pediatric pain. So without ado, we'll have Catherine lead off the session. Go ahead, Catherine. Thank you for joining us.
Great, thank you so much. Okay, I'll just get up my slides here. You can see that okay? So thank you so much to the Chronic Pain Network for allowing us to be here today to talk about SKIP. We absolutely love the opportunity to showcase everything that we're doing. And I think this is a particularly very exciting opportunity for us because this is our first time all getting to speak together, the knowledge brokers and myself. So that's really great. So the name of our talk is Engagement is Key, Solutions for Kids in Pain. Knowledge. So we are a cross-Canada team, as you heard. So we have Paula, who's the knowledge broker and is based in Ottawa. And then we have Chad, who's based in Toronto. Elise wasn't able to come today because she's actually currently having her baby, but we have a recording from her. So she will be still contributing to this amazing talk. And then we also have Erin, who is in Halifax, like myself. And when we were talking about doing this presentation today, I really have to hand it to the knowledge brokers because we talked about different topics and what we really wanted to showcase. And they said, you know what, I really think that this has to have a huge patient engagement focus. And they really gave me a lot of leadership and said, you know what, Catherine, I think it would be great to do this together, but also have you lead it from a lived experience lens and your work in patient engagement. And they've done a lot of amazing work in patient engagement themselves, which you will hear about. But I'm going to hand it over to Erin for now, and she's going to go through a little bit of the background of how SKIP came to be.
Thanks so much, Catherine, and thanks to CPN for having us all here. Catherine, you're very kind, I think, to give us that credit, but I think we are very, very grateful for your leadership and kind of leading the ship here and steering this all together. So we are excited to be here. So I think all of us who are very inundated with SKIP, I think know tons about SKIP, but we hate to assume that everyone knows. So if you do know a bunch about SKIP, please disregard the next couple slides, but just so we're all on the same page, we did want to share a little bit about Solutions for Kids in Pain, or SKIP as we like to call it. So SKIP is a national knowledge mobilization network, and our mission is to improve children's pain management by mobilizing evidence-based solutions through coordination and collaboration. And so as you can see in this beautiful graphic, we're located across the country. So we have 4 regional hubs located across Canada, where each hub has a hub lead, so that's either like a clinical or research or leadership expertise who works with one of us, a knowledge broker across the country, to implement knowledge mobilization activities through evidence-based solutions at each of our institutions, and then also branching out into our regions. And on the next slide, we talk a bit more about, so SKIP is driven by the shared vision of wanting to protect children from undertreated and preventable pain. And also those immediate and long-term side effects that can come from that, or the result of that. And so this really matters because pain that isn't treated well causes unnecessary harm for children's brains and their bodies. It can be traumatic for both patients and families, but then also traumatic for those healthcare providers that are at point of care providing that care. And ultimately can cost the healthcare system time, money, and as those both are, resources. We know that poorly managed pain in childhood could actually have serious consequences later in life, whether that's healthcare avoidance or increased risk of chronic pain and addiction. And so when SKIP was in early days, it was identified that this area is clearly ripe for innovation. And it's just really, really important. And there's a huge need to get that evidence into practice. On the next slide, we talk and we show about this commonly cited statistic that it can take up to 17 years for research to get into practice. And this has traditionally been the case, and really it's a leaky pipeline. So if you can see, as we go down to the right side of the slide, only about 14% of this actually makes it to the other end of that pipeline in 17 years. And when you're thinking about child health or kids health, 17 years is an entire childhood for a cohort of children. So that's a really big deal. And children's pain, I think, is such a great example of this. And I think we all know this so well now, is that there is so much practical evidence. So there is so many great things that can be done to be provided to healthcare professionals or institutions or patients and families to better their experience. And so that's essentially what SKIP and what we are doing. We're really working to reduce this gap. So this long leaky pipeline, we're working to make it shorter and more efficient to get research into the hands of those who need it. And I think an interesting aside too is what COVID's kind of showed us is it really shows us how we can actually shorten this pipeline to take evidence and make action with it if there's the right motivation and resources in place as well. On the next slide, we're talking about how we're funded. So we are very, very fortunate to be funded by NCE, or Network Centers of Excellence, which is a federal funding initiative that within their KM, or their knowledge mobilization stream, focuses exclusively on knowledge mobilization. So they're founded on the fact that knowledge that sits on a shelf helps nobody. So the NCE KM stream connects those who generate knowledge with those who need it to put it into practice. Any researchers in the audience, I think, will know what an incredible luxury and opportunity it is to have time, money, and resources to have that focus completely on KT or KM instead of trying to squeeze it in at the end of the grant off the side of your desk. And so NCE's model is such that they support innovative partnerships. So outside of academia, with industry, government partners, nonprofit as well, across many, many sectors and disciplines. We're very fortunate to be able to work with those. We also are incorporated as a not-for-profit. So while we are hosted at Dalhousie University, our administrative center, and then throughout hospitals across the country, we are also our own nonprofit entity. And we also are required to have a co-leadership model of a non-academic partner, which is really exciting. And that's Children's Healthcare Canada. So on the next slide, Children's Healthcare Canada is a national member-based organization that serves children's healthcare delivery organizations across the continuum of care. And this partnership is incredibly invaluable to SKIP as it connects us with all their different institutions they have across the country who are members of their organization. And it also allows us to tap into many of their own great KT and KM initiatives that you will learn a bit later on from Paula.
Awesome. Thank you so much, Erin. So I just wanted to give everyone a little bit of a background if they are not familiar with patient engagement. So when we talk about the amazing work that we're doing, I just wanted to let everyone know that we are not forgetting about the people that we intend to serve, which are patients and families. So for anyone that doesn't know, I just wanted to give a definition of what patient engagement is. So it is meaningful and active collaboration in governance, priority setting, conducting research, and knowledge translation. And that is CIHR's definition of patient engagement. So when we talk about engaging patient partners in the work that we're doing, we don't just do it because it's the right thing to do. I think that a lot of people think that patient engagement is the morally correct thing to do, but it is so much more than that. it is very much a asset to engage patient partners and be able to have their amazing lived experience be at the table when you are making decisions, when you are doing project activities, because they bring a very unique and valuable approach to the activities that you're doing. They are the ones that have looked and searched for any of the answers. They know what patients and families are looking for. They have experienced the gaps in the system, and they have experienced a lot of unnecessary, sometimes, struggle. So I think that they have a real a key part to play in trying to fix the solution. So just to say that. And SCIP is doing its best to incorporate the lived experience wherever possible. So we have amazing patient and family partners that work with our knowledge brokers, as you'll hear, and do a lot of different activities with us. And then we also have people with lived experience involved in the governance of SCIP. So we have people with lived experience on our board. We also have the Patient and Caregiver Advisory Committee that is co-chaired by Don Richards here today. And they govern the patient engagement work that we're doing. And then on top of that, SCIP also has 2 people with lived experience working as staff members, which is amazing. So there's myself and Milen, who is the communications coordinator. So for anyone that is wondering, what exactly is a patient engagement coordinator? I just wanted to give you a little bit of background. This is very much a full circle moment for me because we are just over a year of having me in this role. And when I was brought on with SCIP, Erin actually had the foresight to say, you know what, we're having so many more activities, which is great. And the knowledge brokers are facilitating so many partnerships and projects. And then we have this key interest from patient and family partners to be involved with SCIP. We need someone to coordinate these connections and also support the patient and family partners that are engaging with us so that it's a meaningful experience for them, as well as support the project leads to look for areas where they can be including our family partners. So yeah, we do these activities all across the country. So we have Samina, who's working out of Stollery Children's Hospital, and she is our hub lead there. We also have our hub lead, Fiona, and our hub lead, Jennifer from Sick Kids. And then we have Alan at the IWK Health Center and Emily from Children's Healthcare Canada. So these are the hub leads and the bosses, the not so scary bosses of our knowledge brokers. So we function with a hub and spoke model. So that means that the activities that are being done by the hubs also fan out and support the work of the institutions and their regions. So these hub leads have done an amazing job and really support our knowledge brokers to facilitate a lot of these projects in their particular regions. So as you heard, we have our knowledge brokers. So Elise is working with Samina, Chad working with Jennifer and Fiona, Paula working with Emily, and Erin working with Alan. And for any of you that are wondering what exactly is a knowledge broker, that is one of the first questions I had when I started in this role. Erin said, you know what, we need to actually explain what a knowledge broker is in this presentation. So she's going to give a little bit of information on that.
So when Catherine asked me that question, and when many people ask me that question, even if all of yourselves listening to this are asking yourselves that question, if you haven't heard the term knowledge broker before, you're not alone. It is a newer-ish one where for years, I think people have been acting in these roles more informally, and only more recently are organizations actually carving out these specific roles the way they have for Paula, Chad, and myself. Knowledge brokers act as intermediaries, so they serve as change catalysts who are continually engaging with different stakeholders, facilitating the execution of knowledge mobilization activities within and across our network, and they support healthcare regions in their organization. So like Catherine said, that hub and spoke model, or across the country. And we do that by beginning with those who have the greatest capacity or the greatest readiness for change to access, adapt, and implement evidence. Us as knowledge brokers, or also KBs as we're endearingly called, constantly are developing relationships with and between knowledge producers. So those are those trainees or researchers, and knowledge users. So those are those people at point of care who are really looking to get this evidence in their hands so they can affect positive change. And on the next slide, some of you may resemble this and be all funny and squinty eyes saying, but really, what did she just say? That doesn't make sense. A KB what? So we're going to walk through some examples of the types of KM work that we each lead in our regions as KBs, and how we work side by side with incredible patient partners like Catherine and many other folks across the country that ultimately makes our work more impactful to knowledge users across the country, and helps us as well.
Yeah, so we have not an exhaustive list, but we wanted to highlight some types of knowledge translation / knowledge mobilization activities, and I'm using this interchangeably for anyone that is wondering. So this is just a list of activities that SCIP has been very much involved in and has done a lot of great work in. So we have some examples on our website, but our website is currently being revamped, so stay tuned. There will be more resources available if you're looking for examples. But we have sort of these traditional materials. So whether that is virtually or actually handed to people as pamphlets, there's opportunities for guides and toolkits and pamphlets. And it really just depends on the amount of resources you have to create these documents. So SCIP has done an amazing executive summary with CIHR on opioid prescribing, and this is quite elaborate and can be found on our website, but there are lots of different ways to do this type of knowledge translation activity. You can very much do a one-pager document that is still very, very helpful and effective, and my tip would just be to try to make it as visually appealing as possible. So then we also have plain language summaries, open access publications, conferences, hopefully patients included conferences, these types of activities where you can showcase your work. These are more traditional knowledge translation activities. So I really, I welcome people to think a little bit outside the box and try to do a couple of activities that also access different types of knowledge users, which means people that are accessing this information, and patients and families maybe don't have the resources that that researchers do in order to go look for these summaries or in order to go look for these publications. So we really want to bring the knowledge to them whenever possible. So then also policy briefs are really great. Obviously, you have a huge potential to impact lots of people if you have the right reader reading your policy brief. We have the opportunity to showcase your work with newsletters. So SCIP actually has a newsletter, and we very much do feature the amazing work of researchers in different communities across Canada and the work of our amazing partners. So it's called In the Loop, and you can sign up for our newsletter. We'll include the link at the end of this presentation. You can also do workshops, whether that be at your local university or on a larger scale. There's also opportunities to do in-service training or professional development opportunities for whether that's physicians, whether that's healthcare providers, giving them the knowledge that you have learned from your research. So SCIP does this with the rounds. So it's an opportunity for physicians to learn about research. So we have done a number of opportunities with them and showcasing pediatric pain work. So there's also traditional media outlets. So we have done a number of interviews, and really COVID in some ways has given a lot of healthcare providers and researchers the opportunity to showcase their work. So in terms of needle fears, there's been a lot of conversations around people getting the COVID vaccine, and a lot of interest from the media on that. So leveraging that in order to get your goal across and your mission across. There's also podcasts. People don't think about this. I did a Matters of Engagement podcast, which was really cool and neat, and was a fun way to access different listeners. You can also do social media, so you don't have to create, your own social media account. Although for some labs, that's definitely really great. But you can also be featured on someone else's social media, like SCIP, for example. There's also the opportunity for blogs. So we worked with our SCIP affiliates, and they did this amazing Painfully Aware blog that was written by someone with lived experience, and she wanted to share some of the things that have worked for her in the past. but there's different ways that you can showcase the knowledge that you've learned in blog opportunities, whether that's also a website or being showcased on someone else's website, or promotional videos. Really, the opportunities are endless. And we are very happy to help with any of these if anyone is struggling with that and wants some advice. And we'll get into that later in the presentation. So I also wanted to go through, so we have these amazing benefits to knowledge translation and knowledge mobilization. And these are really the end goals. And they were laid out by Melanie Barwick's Knowledge Translation Planning Tool. And this is used by our knowledge brokers. And I'll just get Erin to add it in the chat if possible. So I really wanted to go through these from the lived experience lens and why I think this ultimately is benefiting the lives of patients and families. So when we talk about informing researchers, sometimes people think of the research as automatically being read by other researchers, but sometimes it kind of gets stuck in a particular discipline. So knowledge translation activities give the opportunity to access different researchers from different disciplines and on a larger scale. So there is a huge potential to inspire other researchers to get involved in pain research and incorporate your ideas into their work. So there's also sharing knowledge. So I very much have benefited from a lot of knowledge translation activities. So whether that was attending conferences or some of the work that Skip has done, I have learned so much and have used a lot of these strategies myself. So just to say that these activities are really great and really do get to the hands of patients and families and really help us in managing our pain, because there's only so much time you get with a doctor in a doctor's office. They obviously can't give you all of the information that is out there. So if you can access patient and family members directly in order to manage their pain, then that's an awesome opportunity to do so. There's also generating awareness. So I think when we talk about this, there is a lack of awareness. Sometimes it's funny because I've been working in this space so long, sometimes I forget that some people don't even know what chronic pain is. Some people don't even know that kids have chronic pain. They don't believe in chronic pain, or they don't want to learn about it. And there were so many times where I was in school and I wished that I could walk into my principal's office and say, look, listen, look at this research. It does exist. I'm not crazy. So I think that there's a huge opportunity with knowledge translation activities to educate the broader public, and also potentially educate teachers and peers and people that are having an impact on people living with pain, and maybe people that don't have as much knowledge. And these relationships are very difficult when someone doesn't believe that you're in pain. So there's a huge opportunity there. Facilitating policy change, obviously you have the opportunity to really impact a large number of people if you can get some of your practices into hospital policies or government policies. Facilitating practice or behavior change. So that means in the doctor's office, or the physio's office, whatever that means, potentially improving the practice of healthcare providers is awesome. Informing decision-making, people that have the ability to make these priorities. And then when we talk about commercialization and technology transfer, we say all the time, getting knowledge into the hands of those that need it, but this is quite literal when you talk about commercialization. So getting a cream into someone's hands, or a particular device that could help them. I know that I have tried so many, and many are not evidence-based. So trying to get a lot of evidence-based technology into the hands of patients and families is very important. So these are just my my perspectives from someone that lives with pain, but I just wanted to go through those. So I will let the amazing knowledge brokers highlight some of the work that they're doing with patients and families. So I'll let Paula go first and show some of the work that she's been doing with patient partners.
As mentioned, thank you, Catherine. As mentioned, Children's Healthcare Canada is a co-leader or co-director of SKIP out of our offices in Ottawa. And our role is to leverage our knowledge mobilization program and other assets like our family network, as an example, to further the mission and objectives, priorities of SCIP. So our knowledge mobilization program currently has a number of components, a couple of which are our webinars and our Spark e-news bulletin. We've also recently started podcasts, and there's one in the works related to pediatric pain coming up, so stay tuned for that. We hosted, coordinated and hosted 8 pediatric pain-related webinars. Each of those webinars required patient input in order to share the evidence through researchers or practitioners, the implications for practice, but also the implications to the lived experience, either from a child perspective or from that family's perspective, is really important. So we make sure that those voices are heard through those webinars. Our Spark e-news bulletin has a SCIP section where we feature and more broadly share SCIP resources and other evidence with our roughly 9,000 subscribers across a network of 250 organizations. And we have an annual conference where SCIP has a considerable profile as a sponsor and the host of concurrent sessions and workshops, all of which engage patients in their delivery. And our next steps with regard to the knowledge mobilization program will be the podcast and some pop-up events. So those are sort of mini conferences that we have where pain is also featured fairly actively through that. The last one was around transitions in care, which definitely relates to the pediatric pain community. And the next one coming up is children with medical complexity, again, quite relevant. We also co-lead with Katie Burney the development of a pediatric pain management standard through HSO, and patient partners are engaged in a number of ways, one of which is as equal members of our working group, and the next is through 2 stages of public review that we will engage our Children's Healthcare Canada's Family Network, as well as the patient partner network from SCIP. And you heard some of the media lists of resources that are used in knowledge mobilization with families and patients. And one of which is a partnership with SCIP and the Conversation Canada, where we're publishing 6 articles on pediatric pain related issues for the general public and patient populations. Currently 5 articles have been published and 1 is in development. And the Conversation Canada has to have academic authorship and they don't enable authors who are non-academic. So our next step in patient engagement as it relates to Conversation Canada is to develop responses to those articles or articles related to the same topics in other media like Parents Canada. We're also developing or revamping a patient toolkit, and there are a number of family resources in there, and we're soliciting families to provide us with resources that have assisted them that we can catalog in that toolkit. And that's among those activities that we're doing. And of course, as a knowledge broker with SCIP, we are collaborating across hubs as well to share what works in one hub with other hubs across the country to make sure we can have a pan-Canadian approach to children's pain management. Thank you, Catherine.
Awesome, no problem. I'll let Chad go next in his work in engaging patient partners.
Great. Thank you so much, Catherine and Paula. So good afternoon, everybody. Very, very excited to be here today. So as you can see, Paula gave you a very broad array of excellent ways that Children's Healthcare Canada engages their patient partners. And I was hoping to give you more of a specific example today. So I wanted to talk to you about our Patients Included virtual conference called Conquering the Hurt. So this conference was hosted by the Sick Kids Pain Center, Pain in Child Health, and Solutions for Kids in Pain. And it focused on disparities in care, equity, diversity, inclusion, and pediatric pain, and was designed, planned, and executed with patient partners. So I can get the next slide, Catherine. So before we begin, so the conference did adhere to the Patients Included Charter. If anyone doesn't know what that is, I can explain it now. So it includes incorporating patient partners in the planning of the event and selection of themes, topics, and speakers. It also includes people with lived experience that address issues that are in the event and participate and are part of the attendees. So they're speaking and involved in the audience. That all expenses are paid in full, and that patient partners and people with lived experience can attend for free, and that all disability requirements for participants are accommodated. So the event itself actually had over 30 speakers, over 300 attendees. It had breakout rooms, Twitter engagement awards, world-renowned keynote speakers, and much, much more. And we can largely attribute this success to our incredible patient partners. So as you can see from, not this exhaustive list, but this long list, we were able to have a large international presence. We gained a ton of new followers on Twitter because of the social media efforts by our patient partners. We had over 60 new members join the Sick Kids Pain Center membership, and we were able to address very timely and important topics in equity, diversity, inclusion, mental health, and COVID. So next slide, please, Catherine. So, our patient partners really enabled us not only just to think outside of the box, but we're really able to grow the number of our attendees, which really made our event more wide-reaching. It allowed for more diversified expertise, which added to a greater variety of questions and opened up our minds to new ideas. It also enabled us to connect with organizations and people outside of the pediatric pain space, which was a great advantage. And the other awesome thing is that we were able really to understand how COVID was affecting people's pain management at home, but from the lens of a person with lived experience of pain. So we felt very privileged to get this real insider information, because our audience was therefore able to get a glimpse of how unprecedented events like COVID can affect someone who's dealing with chronic pain. And because of our patient partners, we were also able to rethink how information was being presented and if there were ways we could better cater to our audience. And along this line, our conference agenda and resources were improved from that. And patient partners also did a lot of little things like notifying us, that sending patient and family resources in the chat box would be a good idea during the live conference. And because of this, this actually increased our traffic to our websites and our partner websites. And the list really doesn't stop there. There are so many benefits of having patient partners involved in developing big events like a conference. And it really adds to the authenticity and magnitude of the event. And we feel really lucky that we had this opportunity and really cannot wait for our next one this November, where we look at amplifying patient engagement and patient partner involvement once again. And the last thing I'll say that's really important to remember is just we have to really acknowledge how much expertise and experience patient partners bring to the table. The best way to maximize impact is to integrate patient partners in everything you do. And it's really a mistake to make assumptions on what you think might be happening, and is therefore crucial to involve experts who know what's happening. So thank you, and I'll pass it back to Catherine now.
Great, thank you so much, Chad. So I'm just going to play Elise's overview of her projects that she's done in collaboration with patient partners.
Hi everyone, my name is Elise Ryder and I'm the SCIP Knowledge Broker for Western Canada, based out of the Stollery Children's Hospital in Edmonton. I'd first off like to extend a sincere thank you to all of you for attending today's webinar, and respectfully acknowledge that I'm speaking to you as an uninvited settler on Treaty 6 territory, traditional lands of First Nations and Métis people. Today I'd like to share with you two of the knowledge mobilization initiatives I've worked on with some of our patient and parent partners. For those of you who may not be aware, in Alberta, we're currently transitioning to a new electronic record system called Connect Care, which is being rolled out in waves over a number of years across the province. One part of Connect Care is called My Health Alberta, which is a provincial website that provides information to patients and their families on a public-facing website, as well as feeding this information into Connect Care in the form of printable patient care handouts, which can be provided to patients by a healthcare provider. Since early 2020, SKIP has been collaborating with My Health Alberta to review, revise, and create new handouts on pain and painful conditions in kids. In the spring and summer of last year, the Edmonton SKIP Hub engaged a number of different partners to review the information already available on My Health Alberta. We worked with physicians, nurses, and child life specialists to review the existing content to make sure it was up to date with current evidence, but we also engaged parent and patient partners to help us review this material. We were so thrilled to collaborate with our partners on this project and learn from their diverse experiences. By engaging our patient and parent partners, we were able to provide feedback to My Health Alberta that addressed how children with disabilities often have different requirements to adequately manage their pain than able children. And we were also able to highlight alienating and paternalistic language that needed to be changed. Making these changes on a provincial website can take time, but we're so happy to say that the feedback provided by our partners is being incorporated into these patient care handouts over the next year as My Health Alberta makes continual updates to their content. We've also been so fortunate to work with patient and parent partners on a project we're currently developing to better understand how we can improve children's pain management at the Stollery. Through our discussions with families and healthcare providers, it's become quite clear to us over the last while that kids are still experiencing a lot of pain when they come to the Stollery, be it from procedures, surgeries, or presenting with pain. And there really does seem to be a lot of information lacking when it comes to sharing knowledge with kids and their families that will help them advocate for better pain management. So we've been working again with our partners to co-develop an interview guide that we can use to ask other patients and family members about their experiences with pain at the hospital. While we've had some general ideas from a SKIP perspective about what direction we wanted our interviews to go, our partners were so generous with their expertise and experience to help us not only choose the right questions to ask, but phrase them in a way that will be sensitive to the fact that it may be unpleasant for some kids and their family members to discuss the painful experiences they've had at the hospital. Some of our partners have also agreed to help us look at the data we gather and determine what sort of resources we can co-develop as a result of these interviews. So there's a lot of different ways to consider levels of patient engagement, like Sherry Arnstein's ladder of citizen participation, but I chose to share the IAP2 table of public participation here. As you can see, there are a number of different levels of engaging with our partners, and we really try to involve, collaborate, and empower our partners whenever we can. I'll admit that there's times when we sit more in the inform or consult range, but I really do feel that we can create the biggest impact for patients and their family members the further right on the scale we can go. We work with so many different stakeholders and knowledge users as knowledge brokers with SKIP, but having patient and family voices being the center of our work is really when our work can become powerful, meaningful, and create real change. It's been very important for us to move away from the tokenistic involvement of one or two partners on an occasional basis, or exploiting partner stories to illustrate a point about pain management being important. Our work only really makes sense when we're uplifting the experiences of our partners with lived experience and ensuring their voices are heard to make real change. I hope I've been able to share some of the ways that we're doing that locally in Alberta with you today.
Great, thank you, Virtual Elise. I will let Erin go into her initiative that she did in Halifax that I was a part of as well.
Hi everyone, my name is Elise Ryder and I'm the SKIP knowledge broker for West.
Sorry.
Awesome. Okay, thanks so much. So just to round out all these amazing examples, listening to everything we do, I feel like it's incredible to hear all the different things that we're involved in. And in great work that's going on across our country. So I guess I just wanted to talk about one example that we've done out east in it's more of a typical kind of knowledge exchange event. So we worked with CIHR, or the Canadian Institutes for Health Research, on a Best Brains Exchange, or a BBE. So a BBE is an event that brings together senior policymakers and researchers and implementation experts to discuss a high priority topic or a health shared interest, which policymakers have kind of identified as that they want to learn more. So in our province, we were able to bring together CIHR, so that's a national funding body for health research, our local funding body, so Research Nova Scotia, so that would be for the province of health research, all of our health authorities, so the Nova Scotia Health Authority and then the IWK Health Center, so both adults and children, and then also our Department of Health and Wellness, so where our health minister sits and where those provincial decision makers also sit as well. And our event was called Towards a Provincial Pain Strategy for Nova Scotia. So we were super fortunate to have amazing speakers all the way from Australia, the NIH in the States, Alberta, Ontario, British Columbia, and bring together over 60 different stakeholders in the province to kind of start talking about what a provincial pain strategy would look like for Nova Scotia. We had such engagement from the CEOs of our hospitals, even the Chief Medical Officer of Health in Nova Scotia, who I feel like every Nova Scotian is very well in tune with because he gives us COVID updates almost daily now. So it's good this happened pre-pandemic because he definitely would have been maxed out back then. And ultimately, and most importantly, I'd say we also had patient partners, which I'll touch on just at the end, but they were very much involved in the creation and the goings on of this day. An opportunity which is really neat was that we were actually able to also collaborate with Health Canada. They were super interested in what we were doing in our province, and they were doing their engagement sessions, a part of the Canadian Pain Task Force, a mandated kind of body from Health Canada, that they piggybacked on our event and leveraged the stakeholders and kind of expertise, whether that be patient partners or clinicians or decision makers in our province, to create kind of an Atlantic pain listening event. So it was really neat to kind of see those synergies come through. And in reflecting on this, I think it was really interesting because these events, I think, historically have been happening for years with CIHR. And again, they've come out of a need of policymakers saying, hey, we really want to learn more. We have these budget lines. What's this evidence? Or how do we impact change? Or how do we implement this evidence most effectively? And obviously in a financially sound way as well. And I think these are some high level conversations, which historically, again, would be happening behind closed doors. That is kind of the allure of a BBE, in the sense that it's kind of an in-camera session. Kind of the ground rules are what happens in the room stays in the room, different things like that. And so when SKIP was brought to the table, and super fortunate to convene all these players, as being a Patients Included organization, we were like, all right, well, we're going to start to circulate the background or in the agenda to our patient partners to ensure that it's appropriately informed and we're kind of on the right track here if we're starting this progress. And we had a little bit of pushback, and just in the sense that this isn't historically how we do things. We're not sure how decision makers will react in different things like that. And it was a really kind of interesting experience. I think it was really great that SKIP was able to be involved so much and almost capacity build and help everybody involved who maybe typically didn't work in the patient engagement space to begin with, to kind of see that value add and that impact of engaging with patient partners throughout the event. And I think so much so full circle that we actually opened all of the day's events with patient partners kind of giving us grounding presentations to say, hey, this is why we're all here. And I think having consistent feedback throughout the day, from whether it be like CEOs or management level, being like, wow, this was so impactful. It was so helpful to kind of have this lens to approach the rest of the day and to really understand why this is important and why we're here and why it's just not another portfolio or another mandate. So I think it was a really neat capacity building kind of experience that came out of a more typical event.
Thanks, Erin. And I totally agree with you. It was amazing. I had an amazing time and learned a lot. So I just wanted to add in here that Jump In with SKIP is a program that we have. So if you need any advice from our knowledge brokers, they would be happy to consult with you. This program aims to support pain research in their study designs and dissemination efforts. The product has managed to engage several champions from pediatric pain management and has resulted in successful funding for related studies. The Jump In with SKIP menu has been developed as a tier system, as we want researchers to be able to work with SKIP for knowledge mobilization, no matter what the size of their grant. It is completely individualized to the project and the researcher, depending on the goals of their research. beginning with a free consultation and some services that are donated in kind from SKIP. So please feel free to email us at contact@kidsofpain.ca if you are interested in getting help from our amazing knowledge brokers. So now I'm just going to open it up for any questions, but I just have some places where you can check out after this if you would like. We're also going to add in the chat if you would like to be a patient and family partner with SKIP. So I will add in the link there, and there's also a link to our newsletter.
Thank you so much, SKIP team. This was fantastic. I mean, the amount of work that is being done by SKIP is kind of, it's a lot. It's a lot. It's hard to take in really the scope of the work that you guys are doing. I think it's really appreciated for both people living with pain and for people who are working on combating pain. So thank you on that behalf, I think. And there's a lot of questions that have popped up in the chat, and there's a couple that I have written down here as well. I know, so Leslie had written here, how do you decide which research gets transferred, I guess, transferred towards getting mobilized and translated? And do researchers contact you, or is it organizations, or is it patients? So I think that one you've kind of answered, right? That it's primarily the researchers and the organizations who come to you. So how do you decide about what research gets transferred over to translation and mobilization?
I'm happy to jump in, but I see other people unmuting.
I think at least one criteria has to be the quality of the evidence itself. So there's a level of critical appraisal of the write-ups of the studies, be they published or presented to us as a potential proposal, for example. But apart from that, it also is about relevance in the Canadian context, as an example, or transferability to the Canadian context. And its potential to spread and scale from wherever the research was conducted or the quality improvement study was conducted, and its ability to be able to spread and scale and the readiness of others to take that up.
Mm-hmm. So I guess this also goes into the next question, which is how are clinicians involved in this process? Are they involved in the decision-making process as to what's a good project to move forward? Are they involved at the ground level? How does it work with you?
Sorry, I missed the first part of that. Is it how patients are involved?
No, clinicians. How are clinicians involved? Yeah.
Oh, so I would say clinicians, I think, are involved as they can be counted almost as a knowledge user. So they're the end user group, which is really similar to a patient partner in the sense that we really want to make sure if we're creating and tailoring resources that they're going to get to them. And so, for example, we have a partnership with a startup organization in Halifax called The Rounds, and it's like a Facebook for doctors sort of thing. And so in that case, they're our end users. So we make sure that we're going to where they already are to share information, answer questions, and kind of have facilitated discussions. But I think as they're kind of one of our user groups, they are always involved. I think maybe it would be safe to say. I think it maybe isn't necessarily just doctors. It can be across the allied health spectrum. I don't know if anyone else wants to jump in and say it more eloquently.
I don't know about more eloquently, but a number of the members of our network are clinician scientists. So sometimes they're practitioners as well as academics, and the research can come from them. And then it really depends on what the research is indicating. If it is about practice change, then they need to be involved just as patient partners need to be involved as the end user, so we can understand the context and adapt any intervention to the local context without losing sort of what are the core components of what makes that work.
Mm-hmm.
Can I add a fun fact? So Dr. Finley, who is the amazing hub lead at the IWK, was actually my pediatric pain physician when I went to the IWK. So very much having him as a hub lead, I think very much prioritizes patients from the clinician perspective. So it's great that we have him. And obviously as well, I'm sure other people feel that way about Fiona and about Samina. So.
And I think that's something that's unique to Skip, and it really works in the model that we have, in sense that, I guess, to me, I'm just like, of course they're involved in the process, but it's because they're inherently built within our network, in the sense that they are in these leadership roles, they're in these advisory capacities that just exist within our network. So we can bring in additional folks all the time, which is amazing, because everybody has their own connections, whether it's in pediatric anesthesia or pediatric emerge or different things like that, depending on where our hub leads are. But it's really neat that they are always at the table or always engaged in our activities, kind of listening and able to lend their expertise, just because they are embedded within our network, similar to the way we have patient partners embedded with our network. It's another stakeholder that's really key to have at the table all the time.
Are there any questions from the audience? If people want to open up their video screens or put their hands up with the reaction button. I have a lot of questions that I've written down for you guys. I've got a lot. I'm going to start with a follow-up to the clinician question. So I'm a basic scientist, and one of the things that I've been trying to do is to get out the importance of the research that we do in the lab with mice. And so we've had discussions on our end with the chronic pain support group in Kingston, with the multiple sclerosis support group in Kingston, the spinal cord injury support group. However, it's been very difficult to get the word out, in a larger scale, right? Because it's basic science. And I was wondering what you may have learned in terms of strategies for basic science to get the word out at the same level, if you will, as what you're able to accomplish with Skip.
From my perspective, basic science, you are translating generally less to practitioners and more to other researchers, or potentially a view to commercialization or tech transfer. But the principles are the same. It's still about involving the end user. It's about getting their perspective. It's about having your findings viewed through the lens of that lived experience or the research experience to ensure, and in your case, to the research experience, to bring it to the next level. It's less about basic science can be translated and transferred just the same as other types of science. It's who's the end user and what do we want them to change about their behavior, their studies, their policies, etc.
One of the things that we've tried to do actually is to have patients with experience kind of inform our research as well. So Leslie is a patient partner with one of our projects, and we have discussions about how her pain fluctuates throughout the day, and that's led to new research questions for our lab to study at the molecular cellular level with mice. And so it's that for us has really been revolutionary in terms of that kind of interaction. And that's what I was actually thinking of, not so much the tech transfer side of it and but more tapping into the patient lived experience and to get that feedback, and so like more of a dialogue than just knowledge mobilization.
So in my definition of knowledge mobilization, it has to be two-way, as opposed to a unilateral from me to you.
Right.
Because I can share what I know about what works, but not without your context in mind for you. Right. I think that integrated knowledge mobilization or knowledge translation starts at the question, exactly as you've said. That way we're doing research that's of interest to people, questions that are relevant. They're more likely to be taken up and something done with them if people see them as relevant, meeting a need, adaptable to their context, and not too difficult from what they already do now. And that involves an understanding of where they're at and what their issues are.
And I think just to jump in from coming from a basic science world, I think Nader, what you're doing sounds amazing and incredible. And I know you're like, I want to do more. What more can I do? But the fact that you're doing what you're doing and you're having these dialogues, you're engaging with that support group, like that's amazing. Like when I'm sure it's a bit more pervasive in the world that I came from because it was several years ago now, but there was none of that. Like people would maybe go do a clinic day in the hospital just to see the disease in action and different things. But I think that's super novel that you are ensuring that there is that dialogue still at the basic science level, whether it's in lab meetings when you're forming research questions. Like I think that's amazing. And I feel like it would be challenging. I think like in our world or when it's like really closer to that bedside or that point of care, closer to the policymaker being like, I'm going to take that nugget and then give it in a policy brief to the premier next week. I think you're doing it more on your own. You're kind of blazing your own path. But I think if it feels weird or uncomfortable, it doesn't mean you're doing it wrong or you shouldn't keep doing it. I think it's just you're kind of almost ahead of your time or you're really you're doing great things. So I think it's really awesome to hear.
Thanks. Yeah. One of the things that we're trying to set up actually, which I think would be really kind of interesting at a local level, but that could become a national thing, is we're trying to set up a people with lived experience hub within the hospital, so because at Queen's, right, it's a regional hospital and it has quite a few patients with diverse diseases and backgrounds of experience, and then the research center is literally next door, and there's a lot of collaboration going back and forth. And one of the things is, there's people who are working on cancer who've never met a person with lived experience outside of maybe, a family member who's, twice removed or whatever it might be. And so I was trying to find a way of setting up a place where people with lived experience and caregivers would want to kind of go to and say, I'm willing to give you advice and ideas for research. And for then researchers to tap into that pool of information, really, to be able to draw from them their feedback on their projects and to integrate them as much as possible into a basic research. Yeah, it's a tough one to get going, but it's just an idea that I've had and trying to, like for pain, we're starting that now. We have that group now within the chronic pain clinic. There's an advisory group for projects and people can go to and ask questions and talk to on a very, open level, which is hard to do sometimes. Yeah.
I think probably Catherine can talk about this because I think this is kind of like our patient partner database with SCIP. Well, maybe it's more just pain focused, not cancer and everything, but also Chad, I know they have an advisory panel within the Sick Kids Pain Center as well to help inform kind of their stuff. So it sounds like you guys could kind of share experiences or things with that as well.
Absolutely. That's a really good point.
Yeah.
Oh, sorry, yes, go ahead.
No, I was just going to say, if you ever want to collaborate with patient partners, reach out to Skip because we have amazing patient partners that are always looking to engage in our projects, and we work with researchers to set them up. So
I will. I've written down the email address, so I will definitely get in touch.
I'll just add on quickly, sorry, just to what Catherine said, is that especially when you involve patient partners from various different backgrounds, you see the amount of applicability that goes across different fields and how that research process that you might have come up with, even though it might not be specific to or applicable to something that's immediately within your field, but if you look across a large variety of different things, you can see how that can be mobilized at a bigger and better scale. So that's one thing about patient partners, is that you might have somebody in there who's a lawyer or in business development or things like that you can leverage, and it really just kind of opens up the scale and the opportunities that you wouldn't have imagined before.
Yeah.
And I think if I could,
go ahead. Erin.
No, go Paula.
There are also courses. There's a patient engagement in research course and other supports that interested patient partners who are brand new to this, who want to figure out what it's all about, can avail of. And I don't know if anybody has that. I'll look it up while you're all chatting, and I'll put it in the chat box.
Great. Yeah, thank you.
And I think, sorry, last thing, and you can ask some more of your questions. I think that too, while we have these actual examples of like Catherine could pair you with patient partners or or like same with Chad, they have such a diverse panel, kind of a part of their thing. I think there's also like the process piece. So if you're looking to like stand up what this looks like to have a database, or to have, like Skip has done, and like I'll give Catherine so much credit and a bunch of our admin center team, but they've worked to kind of create processes to onboard patient partners and to have like a patient partner compensation framework, and kind of those like more arguably back end boring things, but are super instrumental to ensuring that people are compensated appropriately based on this is the role or this is what they do. And then also Catherine has even taken that a step further, just making sure that there is that evaluation piece. So like, do we know that this has been a positive experience for the patient partner? So ensuring that we have that two-way dialogue of checking in mid project with them or interaction to make sure that they do want to, they are getting things out of it. And if there's gaps or if there's needed capacity building on either end, we can support that as well. So we can definitely help with those teachings as well. Arguably maybe less fun, but still super valuable.
Right. No, I think that those are necessary, right? To make sure that it stays a well-oiled machine, because otherwise you'll have problems with it. No, that's really cool. So I've got one more question to ask. I know we're already over time, but I think it's a good one. So it's a two-parter. The first is, if you had to focus on one KT or KM activity for the most bang for your buck, what would it be? And part of that is, how are you able to reach the most people or affect the greatest change to actually help people at the end of the day?
I think I could just start off by saying, it's extremely difficult because there's two ways of looking at it. The more, effort you put in marketing and knowledge mobilization, you do get a larger impact in terms of the amount of people that are potentially looking at your resources, but you don't actually see how far those resources are actually implementing change. And contrastingly, if you go very specific and you want to do something at a hospital or in a department, you can make, some great change, but it doesn't necessarily mean that it's going to have great impact. So that's kind of the yin and yang that I feel like we have at Skip. But maybe others would want to comment on that as well.
One of the main pieces around knowledge mobilization is, what are you transferring to whom and for what purpose? So my answer is, it depends on who, what, and for what purpose. The best way to get information into the hands of physicians and change their behavior is very different than the way to get information in the hands of policymakers to change policy. And it really depends on what your outcomes of interest are.
Yeah. Yes. So I think if you were going after physicians, right, to change behavior in the clinic, what would you suggest?
If you're focused on a single clinic, it might be direct, workshop, hands-on, interactive change. If it's at a broader level, it might be change at the CMA or at the College of Physicians and Surgeons or wherever. And then you involve the policymakers as well as the clinicians who would be impacted by the policy. And it could be within an organization. And again, I hate to give the answer that it depends, but it depends.
Yeah, it depends. Yeah. No, I think at the local level, I think always seems a lot easier because you could literally go to the office, knock on the door, and say, "Hey, can I have 30 minutes of your time and your staff's time?" But at the national or even the provincial and the national level, I think it becomes so much more mind-boggling in terms of the cogs that are in that process that it becomes overwhelming almost. So I think that's why I really am impressed with what the Skip team is able to do, manage all those different pieces, and really on a national and almost international now scale.
And I think
it really comes down to the breadth and diversity of the network, including the patient partners that are in the network.
And I think also it's kind of, both of you touched on this with CMA and Nadie talking about a larger scope, but I think SKIP is small and mighty, and we have tons of patient partners that are not necessarily embedded every day at SKIP, but that we have their support and their expertise. But we also, in which I feel like it's kind of funny because we normally talk about in every talk, but we didn't really talk about how we work in partnership. So we work in partnership with so many organizations. So whether that's CMA or our provincial departments of health or the Public Health Agency of Canada. And so I think that's kind of where your mind's going, in the sense that like it's super easy to go over to the lunchroom at the hospital and say, hey, can I do a lunch and learn for a couple series and kind of get everybody's hands involved. But I think the model that SKIP really benefits from, whether it's working in partnership with patients or people in our network, is that we also work in partnership with larger organizations. How I was talking about NCE makes us kind of do these innovative partnerships. Like that's the model they suggest. And so it would be having that connection to CMA to say, oh, you have these conferences coming up, you have this webinar series, let's embed this in here. Or you're working on new clinical practice guidelines that these clinicians need to recertify every year. Let's get this in there to make sure, because then you can kind of embed again where people are already going or people are already looking to expertise, instead of SKIP being like, we're going to create this whole new thing and hope people see it. Whereas CMA already has this following, or that Facebook for Doctors app already has that following. We can partner with them and then streamline through them instead of hoping that we can bring people into what we're doing and kind of reinvent the wheel.
And we would work, for example, with the regulatory colleges if it was a practice change that we wanted to see embedded, against which they would be evaluated.
Wow, that's really fantastic. I think it's giving us all a lot to think about, and ways to not only help the mission of SKIP, but also to try to apply some of the things that you guys are using towards our own work as well.
And we'd always be happy to dialogue with you about that. If you're trying to work through it and just need to bounce ideas off, that's certainly part of why we're here.
I'm definitely going to be getting in touch. Thank you so much, everybody from the SKIP team. And I'm looking forward to having more of these discussions with you and to hear more about the amazing work that you're all doing.
Well, thanks so much for having us. This was really fun.
Thank you so much.
Thank you,
guys.
Bye.
Thanks, everyone. Have a great rest of your day.
You too.
Bye.